I'd like to share with you a presentation I recently made to my group at the innercircle.drdavisinfinitehealth.com, where we have typically weekly meetings. We talk about these kinds of topics, where we talk about better ways to manage your health and also ways to avoid the misinformation that's very common in conventional healthcare. In this case, let's consider the case of homocysteine. So many people have been tested for this amino acid in their bloodstream and have been told, your homocysteine level is high, you should be on B vitamins, folic acid or folate, B6, B12, sometimes B2 riboflavin. But what does that do? So authorities tell you, reduce homocysteine with B vitamins, but let's look at the evidence. Does that actually address the problem? Does that actually reduce risk for all the diseases that higher levels of homocysteine predict? I'm going to show you that no. Higher levels of homocysteine, yes indeed, predict risk for numerous conditions, cardiovascular disease, stroke, depression, various cancers, blood clot formation, etc. But reducing homocysteine with B vitamins does not reduce the risk for those conditions. So let's talk about why that disconnect develops and what you can do about it. So a lot of time, energy, and money have been spent in grappling with this idea of high levels of homocysteine. Do they predict disease? And does reducing homocysteine reduce risk for disease? So let's review all that and try to clear this whole question up. So it's been proposed, based on numerous human clinical trials, that homocysteine is indeed a marker for numerous diseases. And that reducing, it's well established now, we'll run through all these data, these trials, that reducing homocysteine using an array of B vitamins reduces homocysteine, but does not reduce risk for those conditions. So we're going to review the evidence that I'm going to argue that high homocysteine may have nothing to do with B vitamin deficiency, at least in many cases, but really has something to do, it's a reflection of a disrupted gastrointestinal microbiome and what you can do about it. So I think also that homocysteine is a prototype for much that has gone wrong in modern health and health care, that so many times a treatment is proposed for some condition, but doesn't lead to full restoration of health, full eradication of that condition. And the big gap may be failure to incorporate what's going on in the gastrointestinal microbiome. And I think that's true for homocysteine. So the whole conversation with homocysteine got its start in the 1960s when Dr. Kilmer McCulley, a pathologist who was working with a condition called homocysteinuria in children. These are children with all sorts of problems that are genetically determined. They look different, they have seizures, they have psychiatric disturbances, all sorts of visual problems, osteoporosis. It's a genetically determined condition, and their urine and blood levels of homocysteine are sky high. A blood level, for instance, of greater than 100 micromolar per liter. And these kids also suffered from what he called atherothrombosis. And all that means is atherosclerotic plaque in the coronary arteries, carotid arteries, that led to heart attack and stroke. And these are children. So this occurred in their childhood years, and teenage years, and early adulthood. So he asked this question, well, if high levels of homocysteine cause heart attacks and stroke in these children, could lesser levels, not genetically determined, be a predictor of heart attack and stroke in people who don't have homocysteinuria? So it could be due to a lack of B vitamins. That's easy to work out, though. If you're higher homocysteine, say of 15 micromolar, not the 100 of the homocysteinuria kids, if your level, say, is 15 and you prove to have a deficiency of vitamin B12, well, correct the B12 deficiency, right? Or find the cause for the B12 deficiency, and that can reduce homocysteine. We're not going to address that because that's pretty clear-cut stuff, right? If you have a B vitamin deficiency, correct the B vitamin deficiency, homocysteine drops. But that's not what we're talking about here. We're talking about homocysteine in the absence of evidence for a B vitamin deficiency, where there's an increased risk for coronary disease and cardiovascular events, for stroke, for thoracic aortic aneurysm, which is catastrophic, cancers, various forms of cancers, depression, Alzheimer's dementia, Parkinson's disease. So we're going to run through some of these data to show that, oh yeah, higher levels of homocysteine are indeed predictors of these health conditions. So here's a study that looked at whether homocysteine was a predictor of death. So the people in the purple graph at the very top, those are the people with the highest homocysteine levels. And yes, they had an increase in the likelihood of death. Death from all causes, heart disease, stroke, cancer, anything else. So yes, higher homocysteine did predict higher levels of risk for death. The lowest homocysteine, less risk. The difference is not great, you can see on the y-axis, but there is clear-cut, a graded difference. When you have a graded difference, even though it's an observational or series of observations, it tends to make it a little bit more confident or firm that this is indeed true, that higher levels of homocysteine seem to be associated with increased potential for early mortality. And by the way, so you can see that risk starts to increase somewhere between 10 and 12 homocysteine, micromolar levels of homocysteine. Not the 100 of the children, but somewhere between 10 and 12 micromolar per liter. And it looks as if the MTHFR, those of you who are fussing with that genetic variant, doesn't really play much of a role. And that's a whole other conversation. But the MTHFR genetic variant, like the C677T, really has very little role in predicting mortality, and it's easy to address. So we're not going to address that today, but know that the MTHFR variant is really not the root of the problem here. How about homocysteine as a predictor of cardiovascular events, like heart attack, sudden cardiac death, development of symptoms that justify bypass surgery or stent implantation, or stroke? Yeah, so these are all the studies that have been done to try to answer that question, and it does indeed seem that higher levels of homocysteine, particularly above about 12 to 14 micromolar, and higher of course, seem to predict increased risk for these conditions. So that is well established. You can see all those dots to the right of the vertical line. That suggests there is indeed increased risk for these things in people with higher levels of homocysteine. And so some researchers have quoted these figures that an increase of 3 micromolar per liter of homocysteine can be associated with about a 20% increase in the risk for cardiovascular events. So this is well established. You can see many studies have been done, all confirming that higher levels of homocysteine, yes, indeed, do predict these kinds of events. How about homocysteine as a predictor of dementia? Yes, higher levels of homocysteine do predict greater risk for dementia. It's not in question. This has been established in this and other studies. Likewise, all the studies to the right of the vertical line suggest, yes, homocysteine is a confident predictor of depression. So wait a minute here. If a higher blood level of homocysteine is a predictor of all these health conditions, it would only stand to reason, wouldn't it, that reducing homocysteine by whatever means must reduce risk for all those health conditions. And in fact, many noted authorities or sources of health information like Cleveland Clinic, other places, they all tell you if you have a higher level of homocysteine, particularly above 14 or 15 micromolar, you should be taking B vitamins, particularly B6, B12, folate or folic acid, and sometimes B2 riboflavin to reduce homocysteine. So you'll find this everywhere, that authorities everywhere are telling you to reduce homocysteine, just like they tell you to reduce cholesterol, right? We know it's not in question. B vitamins, B6, B9, folate, B12, maybe B2, reduce homocysteine levels. So here's a study that looked at the homocysteine reduction of about 30% with this menu of B vitamins, in this case 1,100 micrograms of folate, 5 milligrams, a lower dose of B6, 1,000 micrograms B12. Whether people were at home or whether they were hospitalized with some illness, they all experienced about a 30% reduction in homocysteine with that menu of B vitamins. So the capacity for B vitamins to reduce homocysteine, not in question. It is well established. But do B vitamins that reduce homocysteine thereby reduce risk for all these health conditions? And let's talk about how they do not. So here's homocysteine reduced with a fairly significant dose of 800 micrograms of folic acid in this case, 40 milligrams of B6, 400 micrograms of B12, And you can see on the graphs, the people who got that menu of B vitamins had no reduction, perhaps even more cardiovascular events compared to people on placebo. This is about 4,000 people followed over 4 years, so a very sizable study. So in this study, taking B vitamins to reduce homocysteine did not reduce cardiovascular events. No difference. Likewise, another study, very sizable, 5,500 people, watched over 5 years. Once again, significant doses of B vitamins, and while there was a reduction in homocysteine, in the light gray, that's placebo, dark gray, or that darker color, a reduction in homocysteine of about 25%, but there was no difference in reduction of cardiovascular events. So over and over and over again, there are more than this, other studies I'm not showing you, that significant doses of B vitamins do not reduce cardiovascular events. How about venous thromboembolism? Remember those kids? Not only did they have strokes and heart attacks, they also had blood clots in other areas, like deep vein thromboses and pulmonary emboli. So what about people without homocystinuria? What if we give them B vitamins? Does it reduce blood clot formation? Once again, no difference. 5,500 people followed for 5 years on a significant menu of B vitamins, no reduction in blood clot events. How about dementia? So here's a study that showed, yes, you can reduce homocysteine significantly, 25 to 30% with that menu of B vitamins, but there's no difference in the decline of mental capacity upon formal testing with B vitamins. Everybody develops the same risk of dementia, whether or not you took B vitamins. How about carotid intimal medial thickness? That's the thickness of the lining of your carotid arteries. That there may be a very small effect in that at best. How about depression? Once again, in this case, 4,300 females, folic acid, B6, B12, and no reduction in depression with that menu of B vitamins followed over several years. In this case, 8 years. So homocysteine, no question, there's no debate. Homocysteine is a predictor of numerous diseases. But reducing homocysteine does little to nothing in reducing risk for those diseases. Maybe a little bit of a beneficial effect, carotid intimal medial thickness. Some studies show a very small reduction in stroke. But all in all, reducing homocysteine with B vitamins seems to provide very little, perhaps no benefit beyond addressing any B deficiency you might have. So let's ask this question. Is homocysteine really an indicator of the disruption of the gastrointestinal microbiome? I remind you that microbes in the gastrointestinal tract are vigorous producers of B vitamins. So microbes in the gastrointestinal tract produce B1, B2, B3, B5, B6, B7, B8, B9, and B12. In other words, the microbes in your gastrointestinal tract are B vitamin factories. Calling into question, of course, everybody taking B complex or B vitamins in some form, are you really just compensating for the loss of microbes in the gastrointestinal tract, the failure of those microbes to produce the B vitamins your body needs? Because we know that all of us, because of exposure to antibiotics, often many, many courses of antibiotics over a lifetime, to all the other factors that disrupt the gastrointestinal microbiome, herbicides, pesticides, preservatives, and emulsifying agents in processed food, chlorinated drinking water, stomach acid blocking drugs, non-steroidal anti-inflammatory drugs, on and on and on. We have all, as a society, been exposed to massive disruption of the gastrointestinal microbiome, including loss of numerous species that produce B vitamins. So among the best B vitamin producers are various Clostridium species, Lactobacillus species, and some others. And they all produce this broad menu of B vitamins. So could it be that the rise in homocysteine could be due to a lack of production of B vitamins? So yes, homocysteine can be higher, no question. And we know, well-established fact that modern humans have disrupted the microbiome and have lost many B vitamin producing species that could lead to higher homocysteine. So could this higher level of homocysteine really be a reflection of a disrupted gastrointestinal microbiome? So let's look at several examples of that. Here's a study of people who all had stroke and then were tested for the presence or absence of small intestinal bacterial overgrowth. We say SIBO, S-I-B-O. For those of you unfamiliar with this, that I've talked about numerous times in my other videos and elsewhere. So small intestinal bacterial overgrowth is a situation in which colonic microbes, that is microbes in the colon where they belong, fecal microbes, have overproliferated and then ascended into the 24 feet of small intestine. Small intestinal bacterial overgrowth. Now, the odd thing about that situation is that when the small intestine is populated by trillions of fecal microbes, the small intestine is not well equipped to deal with that. And so it becomes inflamed, and the small intestine is already very permeable because that's where we absorb nutrients. Well, when fecal microbes, trillions of them, infest the 24 feet of small intestine, increase its permeability, when those microbes die, those fecal microbes live only for a few hours at a time. So when trillions of microbes live and die rapidly, they release their toxic compounds into the intestines, then into the bloodstream. That's called endotoxemia. So microbes in the small intestine die, release their endotoxin compounds into the bloodstream. That's endotoxemia. And that can go to the brain, arteries, heart, skin, uterus, all of the other organs of the body. So we have to re-examine all we thought we knew about human diseases in light of the contribution of gastrointestinal microbes that exert their effects on other organs through this process of endotoxemia. So in this study, people had stroke, then tested for the presence or absence of SIBO, typically hydrogen gas testing on the breath. Hydrogen gas testing is a way to map where microbes are living in their gastrointestinal tract. And of the people who tested positive for SIBO, they had much higher levels of homocysteine. You can see right there, about almost 17 micromolar as compared to about 13 micromolar of people who had a stroke but tested negative for SIBO, suggesting that it's disruption of the gastrointestinal microbiome, in this case specifically SIBO, a severe situation of microbiome disruption associated with higher homocysteine. So the problem may not be higher homocysteine, it might be the endotoxemia of SIBO. Now, you can see from that, you can have a stroke without SIBO, of course, but it looks as if having endotoxemia increases the risk for stroke, but also is associated with high homocysteine, with the high homocysteine kind of being just a distraction, a red herring, we say. How about this study in people with Parkinson's disease? So that red line shows kind of the ideal level of homocysteine, and look, virtually everybody with Parkinson's disease had higher levels of homocysteine, and the people who had the highest levels of homocysteine tended to test positive for SIBO. So there seems to be a very close relationship of higher levels of homocysteine and testing positive for SIBO. In this mouse study, who were given a diet to increase homocysteine, in this case a high methionine diet, and that's true, that does increase homocysteine. So these mice were given a high methionine diet that increased their blood levels of homocysteine, and then given an antibiotic. Lo and behold, these mice with high homocysteines given antibiotics had a dramatic reduction in homocysteine. Now, why would that happen if the cause was a lack of B vitamins, right? So it suggests that, once again, it's a bacterially driven cause if it responds to an antibiotic. There's also evidence to show that probiotics, in this case kind of a random probiotic, please don't use that list of microbes as reflecting the ideal probiotic. It's not. It's kind of an off-the-shelf, haphazard, random commercial probiotic, but despite that, it still reduced homocysteine levels. So, in other words, if a higher level of homocysteine was due to lack of B vitamins, why would a probiotic reduce homocysteine? It would reduce it if there was some involvement of the gastrointestinal microbiome. And then once again, how about the prebiotic fiber, fructooligosaccharides, that feed microbes in the gastrointestinal tract even a prebiotic fiber like FOS, fructooligosaccharides, reduces homocysteine. So if the high homocysteine was due to lack of B vitamins, why would a prebiotic fiber reduce homocysteine? Because it's microbially driven. And then this study showed that homocysteine combined with endotoxin was especially lethal. That is, it appears that, yes, homocysteine has some damaging effects on cells. It can accelerate inflammation, death of cells. But it's when homocysteine, higher levels of homocysteine, are combined with endotoxin and white blood cell infiltration of organs is amplified. So, it looks as if dysbiosis, but more so SIBO involving the small intestine, that includes loss of B vitamin producing species, leads to higher homocysteine. And it looks as if, when you have SIBO especially, there's an increase in endotoxin. First into the portal venous system, going to the liver, and then the systemic circulation. Both those circulations will have higher levels of endotoxin when you have SIBO, more so than colonic dysbiosis. We don't know exactly how bad it is with colonic dysbiosis, that is dysbiosis confined to the colon, but we do know SIBO, with involvement of the small intestine, is associated with marked increases in endotoxin. So are we really looking at the combination of an increased homocysteine level that's reflecting loss of B vitamin producing species that is part of SIBO, that in turn causes endotoxemia? Is that really the root of the problem? And does that explain why just taking B vitamins doesn't really accomplish much at all? Now, this is speculative. I think we have good evidence to suggest it's true, but there remain a lot of unanswered questions. Like, can you use homocysteine as a tracking device? If your level is highish, let's say 15 micromolar, can you use that as a way to identify SIBO, address the SIBO, and use that as a tracking tool for the success or failure of your efforts to deal with SIBO? Don't know. Probably, but we don't know that for a fact. No one's done that clinical trial. And is SIBO management alone sufficient? Can you do away with the whole notion? Provided there's no B vitamin deficiency, you just have a high homocysteine. In the absence of deficiency, can just management of the SIBO and thereby endotoxemia, is that sufficient? I think it will be, but no one's done that study. And by the way, I'm in the process of designing that study. I'm hoping to get that done sometime later in the year or next year to show, can SIBO management be sufficient to reduce homocysteine? And does homocysteine is it necessary to have endotoxemia to really generate all the adverse effects? Because we know, right? We know homocysteine, high levels of homocysteine do predict all those conditions: depression, coronary disease, heart attack, stroke, cancers, blood clot formation. We know that for a fact. But do you have to have SIBO and endotoxemia for that high level of homocysteine to exert all those effects and lead to all those conditions? And so if you did that, is there any additional benefit to reducing homocysteine by some other means? Nobody knows, but probably not, given all this evidence. In the meantime, till these questions are settled, I think the lesson to take from this is, if you have a higher level of homocysteine, the only thing you do should not be just take B vitamins. It's to think about your colonic dysbiosis, but even more so small intestinal bacterial overgrowth. Address that. And by the way, if you don't know what that means, please see all my other videos. See my thousands of blog posts, WilliamDavisMD.com, my numerous podcasts, my Defiant Health podcast, and of course my books, including my Super Gut book. But in the meantime, so we manage SIBO, and we do that by restoring keystone microbes, including the ones that produce B vitamins. And there's no harm. There's no harm in taking folate, B6, B12, maybe B2 to reduce homocysteine, but I can't tell you that's good for you in any way, provided you have no B deficiencies. But it is clear that just taking B vitamins, despite what all the authorities say, is inadequate, is insufficient to disable the excess risk for disease posed by that high homocysteine level. So there you go. You can see that the information coming at us, the insights being provided by the gastrointestinal microbiome, are kind of dashing all the things we thought. In this case, that homocysteine predicts disease, and reducing it reduces disease. Not true. So there's something lacking here. There's a disconnect. And I would propose to you that until this is settled conclusively, you can address the microbiome doing all the things we do, such as my SIBO yogurt, restoring keystone microbes, getting fermented foods, fibers, prebiotic fibers, and thereby addressing the SIBO and endotoxemia. And I believe that you're going to see homocysteine reduce. We're going to try to bear that out in a future clinical trial, but my prediction is addressing SIBO, endotoxemia will be sufficient to reduce homocysteine and the risk associated marked by that high homocysteine when combined with endotoxemia.